I am Clint Strong from Jordan Valley. So I am a family practice doctor, and I'm here to talk to you today about integrated medicine and how we do things over at Jordan Valley. So I'll tell you a little bit about myself. I was born and raised here in Springfield, Missouri. Went to Kickapoo High School. Go Chiefs. Any other Springfield residents in here? All right. High school? Okay. That's respectable. So born and raised in Springfield. I went away to college. Went down to University of Alabama for medical school, actually. So roll Tide. You know the Tide fans? No. Okay. Are you guys Missouri Tiger fans? LSU? Who else? No other college fans? All right. Well, no sports? Okay, just medicine. Okay. Yeah, sometimes you're doing med school, all you got time to do is study, right? What else? I came back home to the Cox Family Medicine residency in the year 2000. So I was class of 2000 in med school. So I don't know if all of you were even born then, but that's when I was finishing medical school. So I've been doing this for a few years. Residency, I came back to Springfield for residency because of the residency program. I got married right before med school. My wife and I actually wanted to stay in the South because we loved it. We loved Birmingham. Our plan was come back for residency, hang out with family for a couple years, and then go back off again somewhere in the South, maybe Nashville or Alabama again. We didn't know. And then we had our first baby, ended up staying in Springfield because we had free babysitting all the time. So I've been in Springfield ever since. So I'm a Springfield born and bred, if you will. Growing up here, we had two hospital systems, Cox and Mercy. Cox and St. John's back then. They became Mercy in like 2009 or 2010. And I hadn't even really considered working in Springfield as a doctor. I didn't know anything about the residency growing up, but apparently it had been here for quite a while. And came back, did the residency, ended up staying. I worked for Cox for 9 years in private practice, family medicine. So I saw outpatient medicine only. I did a mixture of adults and kids. Saw quite a few kids in my practice because I had a lot of young people in my practice. And in 2012, I made the change and went over to Jordan Valley. So when I went to Jordan Valley, they had a couple of pediatricians that worked with them, and they had just decided they didn't want to work at Jordan Valley anymore, so they left. But they still had about 4 nurse practitioners in the pediatric department. So my boss, Dr. Stinson, who you may have seen speak or heard, I don't know, Matt Stinson's ever spoken to your group last year. Okay. So Dr. Stinson is the medical director of Jordan Valley, soon to take on some other roles, but I don't know if that's public yet or not. No? Okay. So so Dr. Stinson is my big boss. He was actually a year behind me at the Cox residency. So I guess turnabout's fair play. So I was his boss my senior year. Now he's been my boss for the past 11 years. So I've been at Jordan Valley for 11 years. And I've been on the pediatric team ever since. So I started supervising nurse practitioners and seeing kids about 90% of the time instead of 10% of the time. So my practice basically flip-flopped. I still see some adults, but I mainly see kids. At Jordan Valley, we see a lot of sick kids and a lot of kids that have behavior problems. So it was a really steep learning curve for me. Once again, after being in practice for about 10 years, it was like go back and learn a bunch about kids again, and congenital heart disease, asthma, developmental delay, and go back and study all those things and learn a bunch about medications for behavior problem kids. I mean, we had kids coming in to see me that are on antipsychotics and, lots of stimulants, all kinds of stuff, which I thought was kind of crazy at the time. After a few months, it just kind of becomes second nature. So, oh, wow, I'm on the screen too. Yeah, so that is kind of my background. I've been doing pediatrics for 11 years, mostly. Still see some adults. but don't ask me any questions about any new adult medicine, because I don't know. It's hard to keep up with that and with all the ped stuff. So I rely on our pharmacist at Jordan Valley some whenever I have questions about adults with diabetes or different things. And but really enjoy what I do. I love working with kids. As some of you have rotated with me, some of you may rotate with me later, hopefully. And we try to have a good time. We try to learn a lot, and we see a lot of kids at Jordan Valley. We do a lot of well child visits, so you get to really learn what's normal, which I think is great when you're learning in practice or learning in school. Because, for instance, do you know how they teach people to recognize counterfeit money? Anybody know? They give you real money to handle, to look at, to smell, to feel, and study. So they give you the real money to look at so you can see when anything's wrong. So it's really great experience to see lots of normal, healthy kids, because if there's something that's not quite right, you can probably pick up on it. And you don't have to know the solution for everything. You just have to be able to recognize something's not normal and figure out what you need to do about it or who you need to call to take care of it down the road. So that is my background. And then I was supposed to talk about Jordan Valley Integrated Medicine, right? This is Integrated Medicine Talk. So at Jordan Valley, we have a unique approach to the patient. We have kind of a unique clientele. If any of you have done any work for a federally qualified health center or an FQHC or a community health center in the past in big cities, that's what we are at Jordan Valley. We are an FQHC. So what that means is we get some grants to do our building projects from the government. We also get grants for certain programs to like fund special programs where maybe nurses go out and make home visits. But most of our overhead and operating expense is covered by collections, just like any other medical practice. So we have providers that see patients. We bill their insurance, typically Medicaid or Medicare. We also have a lot of cash paying patients at Jordan Valley. And so we bill them, we collect the money, and we use that money to run the operation. So far, it works pretty well. Jordan Valley continues to grow. We continue to expand. We have clinics in, we have a women's and children's clinic in Springfield now over on the west side. We have a clinic downtown right up the street here, just up Kimbrough/Benton on Tampa. And we have a clinic in Marshfield. We have 2 clinics in Lebanon now. We have a clinic in Hollister, and we have a really nice clinic in Republic. So if you rotate on pediatrics in Republic, you might get to rotate with Dr. Morales, and she is really fantastic, great pediatrician, great teacher, and lots of fun. But that's kind of Jordan Valley, the clinics. So how is our approach to medicine different with this integrated approach? We don't just do medical practice at Jordan Valley. A big part of FQHCs is also dental practice. We have lots of dentists that work with us. We have specifically pediatric dentists that work with us on the pediatric team. And so we tried some of that, or that was the beginning of the integration of care at Jordan Valley. It's maybe behavioral health was really the beginning. So if you've been on any rotations like family medicine, internal medicine, maybe psychiatry, pediatrics, you see lots of kids with lots of behavioral problems, right? If you're going to go into primary care, I don't know what the statistic is now, but back when I was doing it, they said 70 to 80% of your patients are going to be mood disorders, depression, anxiety, things of that nature. So a lot of what we do is behavioral medicine, but as a clinician, for most of us, that's not what we want to spend our time on, right? I'm not a trained counselor, and I'm not probably a great counselor. I'm not a big hand holder in the clinic. You know, some people have different personalities. Some people like to hold their patients' hands and walk them through different challenges. I'm kind of the more, hey, pull yourself up by your bootstraps, take a dose of suck it up, and push forward. You know, you're going to have to get through this. So that's kind of more my mentality. So with behavioral integration, the way that works for us is if I go into a room and I have a teenager and they're struggling with some depression, I'm there to do a well child visit, but I can tell something's just not right with their mentality, their affect is kind of flat, they're feeling down. Maybe I say a couple things that should be funny and instead it brings some tears. Then I say, you know what? Let me grab my behavioral health lady and have her talk with you a little bit. It seems like you got some stuff going on. So then I leave the room after my exam, which saves me a lot of time. And I'm able to do the things that I need to do. And then I grab a behavioral health consultant, which is usually a social worker or a therapist. And I tell them a brief synopsis of the case, which is why you guys work on your presentation skills all the time, right? So you can present a case in 2 or 3 sentences and say, here, this is what's going on. Here's my question. Here's what we need to do. Let me know if I need to start some medicine on this patient. So that's usually how my conversation with my BHC, behavioral health consultant, Amanda, goes. So then she goes in, spends 10 or 15 minutes with the patient, saves me 15 minutes of counseling time, and they can actually bill for that as well. So it's great for our organization, helps keep everything running. And we're also able to offer that service to the patient. So not only do they get to talk with me, they also get to talk with the counselor for a few minutes, maybe get a little brief intervention going, and then she will schedule them to come back and see her in a week or 2 weeks, whatever is needed given the specific circumstances. So that was how integration started with our clinic. We have these behavioral health consultants. They come in and work with our patients. They work with us. We work in like a pod area. So a lot of private practices, and my practice for 9 years, I had my own little office, and I would go see patients. I would go back to my office and hang out, listen to music, eat drug rep snacks, whatever it was. Now I go to the room, see patients. I come back to the pod area, and we have various other providers in the pod. I got a pediatric nurse practitioner. We've got a physician assistant. We've got a couple of the pediatricians. We have a couple of behavioral health consultants. We have a pediatric dentist. So another way that we integrate is if I go in the room and I look at a kid, I'm doing their exam, you look in their throat looks fine, but man, they've got big old erosions in their molars, okay? That's a problem. And poor oral hygiene, poor dental health leads to lots of other problems down the road. Nutrition problems, they can't eat right, they can't concentrate to study because they're hurting in their mouth, they get headaches, they might. Thanks, hope you can hear me okay. So, good. So I grabbed the pediatric dentist, either them or one of the pediatric dental hygienists go in, see the patient. They can sometimes work them in same day, or they can get them scheduled right then and there so they can come back in a few days to get their teeth looked at, get x-rays done, get scheduled for our dental operating room, which we see a lot of kids through, and get their teeth taken care of. Unfortunately, it's a huge problem, especially in the population that we serve at Jordan Valley. But we like to think that we're making a good difference and making an impact on them. So we integrate behavioral medicine into our day. We integrate dental health into our day. On the pediatric team, we have kind of been pushing forward with other integration as well, which some of you students have seen in the clinic. We also have speech therapy in our clinic. So when I go in to do a well child visit and they're 2.5 years old and they're not really saying much yet, I can grab my speech therapist. She'll come in, meet the mom, meet the kid, do a brief evaluation, and get them scheduled to come back for their next speech therapy visit. So when you're out in regular practice, if you don't have this integrated model of care, you see the kid, you talk to them, you're like, yeah, I don't really know if this is normal or not normal. It seems like they're a little behind. So let me make a referral. You put in a referral. There's a waiting list at speech therapy at Cox. It's like 3 months long. So 3 months later, they might get in to see the speech therapist if they remember to keep their appointment. So integrating that into our daily clinic is really helpful for these patients. We also have occupational therapy. You all know what occupational therapy does? Because when I was at your stage, I had no idea. I don't know if I'd even heard of occupational therapy until I was like out of medical school. And we'd refer people to occupational therapy, or they would just come by and consult on patients that we had in the hospital that had had a stroke. But occupational therapists do all kinds of stuff. If you have a kindergartner who can't tie their shoes, I grab an occupational therapist. They will come and teach the kid how to tie their shoes. If you have a 2-month-old or a 4-month-old who's got a big flat spot on their head, you may know what that's called. Liam, Andy, plagiocephaly. Thank you. Yeah. So positional plagiocephaly. If they got some plagiocephaly, that's a problem, because if they look the same direction all the time, they get a flat spot on one corner of the back of their head. It actually pushes one ear forward and the other ear tracks back, so they look really wonky and asymmetrical. So if you ever heard the term FLK, funny looking kid, you don't want to end up with an FLK as one of your patients. So you got to get them into OT, and OT will work with them on the head positioning, make sure that everything ends up being good and symmetrical. They'll get them referred to pediatric neurosurgery if they need to, because used to we'd have to have peds neurosurge to get in place for the helmet, a plagiocephaly helmet, which helps shape the skull back into the proper symmetrical shape. But I think now the OTs can do that on their own. So that's actually really nice too. But they do that. They do all kinds of stuff. But if I have a developmentally delayed kid, sensory processing difficulty kid, maybe a kid who's not having a good time in school because they just can't handle a crowd of people sitting at all the desks around them, occupational therapy will work with them and help give them some strategies and coping skills to get them through their day and make them more successful. And again, in the population of the FQHC, the community health population, we see a lot of the kids that have those problems. What else? We integrate now with physical therapy. So we get all the therapies. We got behavioral therapy, we've got speech therapy, occupational therapy, and physical therapy. So if we've got a kid who's 9 months old and they're not crawling yet, I'll grab my physical therapist or my OT, because OTs work with kids on crawling too. But I'll grab my physical therapist. Hey, did you take a look at this kid, make sure everything's working right? We have a lot of kids who don't get much tummy time because they sit in their car seat a lot at home, or a bouncy seat, because the parents are busy on their phones, watching reels or playing games, playing Bejeweled, Candy Crush, whatever the new one is. And so these kids, they sit in their chairs. They don't get much tummy time. So when I put them on their tummy on the table in the exam room, they do what we call like the Superman or the swim, where they have this extending posturing. And that's not normal when you're 4 to 6 months old. So I say, hey, your child have any tummy time? Oh, well, he doesn't like it. He just cries. Like, okay, well, you may have to put your phone down and get down the floor with them and play with them a little bit, and they'll like it better. But I'll get physical therapy in there. Physical therapy will work with them. They'll have them come in the office a few times, do some therapies with them, work with the parents, reiterate the importance of, bringing them along developmentally. So let's see, Summer, did I leave anything out on integrations? Anything else we integrate?
But I recruit for medical and behavioral and then work on them as well. So a few things that I think would be nice to touch on as well is that second confidence.
Yep.
Like that's a very different model, like with Haley out there working with
Yes. So I don't know a ton about that because I've not been there. Come closer. But I didn't mention we also integrate with our OB team because we have women's health over there. We are closely integrated with them as well because we do see the babies once they pop out. And we have dental that sees the pregnant moms. So a lot of these young women, they don't go to the doctor for years until they get pregnant. They get pregnant, they start coming to the doctor. Well, they come to the doctor, we've got them there, and they've got Medicaid. Maybe they only qualify for Medicaid because they're pregnant. So they've got Medicaid because they're pregnant. Otherwise, they wouldn't qualify. But they've also got lots of tooth problems because they have poor dental hygiene, poor oral hygiene, dental caries, cavities, need root canals, whatnot. And so we have an adult dentist that sees the pregnant ladies when they come in for their pregnancy visits. That's also a really nice little catch that we do. And we're able to provide services for people who otherwise wouldn't be coming to the dentist, wouldn't become the doctor. But we do a lot of work with pregnant ladies with dental too.
Yeah, that's something, he's talking about pediatrics, but that's why our women's and children's clinic is a women's and children's clinic. So on the other side of his pod is the women's health team. So you can get them in when they're pregnant, build that relationship, and send them over to a referral, Dr. Strong, and then get their kids in the dentist, and then get them to PT. We can kind of stop some of those generational issues where people don't know where to go or don't know who to talk to. And it really is all about that relationship. And then just from a mom perspective, when I first came to Jordan Valley, I did not want to switch over my care. So I was like, I hire these doctors, I work with them, like, do I want to get personal? But then my daughter needed surgery for her teeth, and you have to get a paper signed from a pediatrician. So why would I go to two different places when I could just come to our women's and children's where dental is, get the form signed, take my daughter over to the surgery center, not have to miss time off work, not have to pull her out of school more. If she needed glasses, I could have seen optometry the same day as well.
Oh, yeah.
At the same time.
I left off optometry so far, but we'll get to them.
Yeah. So that, and then then you have the behavioral health piece there as well. So it's really great, not only for any parent, but especially our population, because they may only be able to take one day off work so they can get their kid in or themselves in, all in one day for what is needed. So I think that's really the beauty of integration, and that center in Lebanon that we're talking about is very kind of innovative because it's connected to an early childhood center. So I have shadowed over there, and I have literally seen them take a baby out of daycare, like walk over to the medical side, get their temperature taken. Beforehand they have all the consent from the parents, and then kind of back over to the childhood or parents that need to come get picked up. And I've seen the staff come get over and get checked out, for things too. So it's great for having that ability. They also can do some of those child checkups virtually to loop the parents in if they can't get off work. They will do that as well. So it's brand new. I don't even know if we haven't even been open there a year.
Right.
So probably about 6 months. And of course, it's far from, where we are in Springfield, but that just shows a lot of the great things that come with starting that innovation model, like the integrated model is what he kind of said, and building off of it, talking about how far you can take it.
Yeah.
And, I never say never at Jordan Valley because we've added so many buildings and specialties just in the 2 years that I've been here.
Happy anniversary.
Thank you. But also, we just opened a month ago, actually, the same day we opened the Lebanon clinic, we opened a stud clinic as well, so border clinic, which is right by our main Tampa location. So that's just another aspect of referrals and how easy it is to just get done and give that holistic care and follow up. Like you said, that was such a great point. You don't want to have to then ask them a year later at their next child checkup if they got with a speech therapist.
Right.
You would never.
Yeah. That's a really nice aspect of it. So optometry, we have optometry right in our building too. I didn't mention optometry, but if we have a kid, we do their vision screening. they've got issues, or they come to us from OCAC, which is like a local, was it Ozark Area Community Action Committee or Coalition, something like that. So they have daycares, early childhood centers, like we have up in Lebanon. But if we get a kid over, they said they failed a vision screen or whatnot, we can set them up with our optometry team, or we can just walk them over. And sometimes they can see them same day. Get the vision checked, get them some glasses ordered. So that's a nice benefit. Behavioral health, I mentioned our counseling aspect, our therapy aspect for brief intervention, but we also do have like full-time therapists who we can refer to internally. So if we have a patient, they're seen by our behavioral health consultants, then they can see them for therapy for 12 weeks or 6 weeks, something like that. And then if they need continued counseling and therapy, they'll get them set up with one of our therapists, our PsyD, and they'll do a little more in-depth behavioral modification therapy, cognitive behavioral therapy, treatment for PTSD, all those things. Not only that, but if we have a patient who's difficult, we're trying them on all the meds that we can think of, and we just can't get them behaving well, can't get them calmed down, can't get their depression improved, whatever the case. We also have a psychiatry team. So we have some psychiatrists, we've got some psychiatric nurse practitioners, and we can send them over there. They'll take the helm for us, take the reins, and work with them on our psychiatric medicines, get them stabilized, and they send them back to us, and we can continue to prescribe those medicines as long as they're staying stable. She mentioned the substance use disorder clinic, the SUD clinic, or MSUD or MITSUD. I forget all the different mnemonics for it now. Are you all familiar with that? No, mostly no? Okay. So if they don't talk to you about this in medical school too much, they should, but opioid use disorder or opioid dependency is a huge problem in our country. As my students know, I've had the pleasure of sitting on a federal grand jury over the past year. So that's been very interesting. I can tell you more about that if we got time, which we probably will. But we see a lot of heroin and a lot of fentanyl on the grand jury. A lot of people dealing this stuff, running it through. They make all kinds of crazy busts, and they bring them to the federal grand jury to prosecute them. And we basically say, yes, go arrest them. So opioid use disorder, and if you talk to some of the addiction medicine specialists, I don't know if anybody's met Dr. Mark Carlson in town. He works at the behavioral health group, is what they're called. They have the methadone clinic. Have you heard of a methadone clinic? Okay. So methadone clinics came about for people who are addicted to heroin. Okay. And basically the idea that most of the addiction specialists ascribe to is that once you are addicted to an opioid, you can never get off of it completely. Okay. You can quit cigarettes. You can get off alcohol. You can stop meth. You're going to be okay. You can quit cocaine. You can get off cocaine. But with opioids, they are, according to them, nearly impossible to get off of and stay off of if you get euphoria when you take opioids. So they had methadone clinics. People would go each day to the methadone clinic and pick up their daily dose of methadone. All right. Methadone is a long-acting, really long half-life. What are the different? There's different receptors: alpha, beta, beta 1, beta 2, mu. Thanks, the mu. Thank you. All right, it's the mu receptor, and I think methadone is a partial agonist antagonist, if I remember right. So it gives you relief from that receptor, but at the same time, you shouldn't get euphoria with it. Some people do. Some people still are able to abuse methadone, but they came out with these newer drugs, Subutex and Suboxone, buprenorphine, right? However you like to pronounce it. That's the best I got. Yes, so buprenorphine. Okay. Buprenorphine is a partial agonist, and they also have a buprenorphine naloxone combination, which is Suboxone. We also have straight buprenorphine, which is Subutex. But so substance use disorder clinic, somebody can walk into that clinic any day of the week and say, hey, I'm hooked on heroin. I'm hooked on fentanyl. It's killing me. I got to get off of it. Can I get some help? And they'll say, you bet. Come on in. We'll get you some Suboxone. I think they usually start them like maybe with a 1 week supply. Since it's a partial agonist, partial antagonist, it doesn't give them that euphoria, but it takes care of the craving. And so the addiction medicine guys would say, you will never be free of that craving once you have it established in your system. And, so if any of y'all have any ideas of like, I think I'm just going to try heroin one time, shoot up once. You got good sterile technique. You know how to use the needles. Don't do it, okay? It's a bad idea. Those of you online, don't do it. So, I remember one case from residency, and this kid came in through the ER. Back then, the Cox residency was at Cox North. We basically had the run of the hospital. We did all the admissions up there. We did the ICU nonstop. So we were doing central lines, intubations, chest tubes, all the stuff that was fun, exciting. So, but we would have drug overdoses come in every night. So that was our bread and butter. Okay, alcohol withdrawal and drug overdoses. Because people would take a bunch of pills wanting to die. That was the psych unit at Cox North. So they'd bring them to Cox North ER. The ER would send them to us. We'd admit them to the ICU for 24, 48 hours. Once they woke up and we got them a little bit better, we'd send them to the psych unit. But this one guy came in, and his friends told the story that they decided they were going to try to treetop. They were going to treetop some oxy. So what you do is you take oxycodone and mash it up, melt it down, suck it into a syringe, and you don't shoot it into a vein, the treetop, okay? You shoot it into an artery, preferably the carotid. Jugular vein, carotid artery. So you shoot in the carotid artery. So they shot a bunch of oxycodone into his carotid, at least they think they did, and he passed out almost immediately and wasn't waking up. So since they had some ketamine there, ketamine rhymes with amphetamine, so they thought, hey, ketamine sounds good. This should wake him up. Is ketamine going to wake him up? No. And ketamine is not for IM use, just for your information. But they took a syringe of ketamine because one of the dads was a vet, so they got some ketamine from the vet. They shot some ketamine into his glute, and that did not work well. Howdy, come on in. So he ended up being in the ICU for a while. He got a huge abscess in his buttock. He was actually prone on the vent with a huge open incision and drainage wound in his buttock. And he was out for like a week or 10 days before he came to. It was really a fascinating case. So anybody ask you if you want to try some tree topping? I don't recommend it. Yeah, I haven't really heard of it since, so hopefully it's fallen out of favor with the drug users. I don't know how we got on that story. Yeah, what's that? So that is how our substance use disorder clinic is very helpful to our population, or anybody that comes in, because it's not just poor people that get hooked on drugs. It's very high functioning people. I had one patient who came in and was a dentist in town. This dentist decided that they were at a party with some friends. They decided they're going to try cocaine. So, I said, how did that go? I said, it was really I didn't like it very much. But after I went home from the party, I was laying there in my bed, and all I could think about was, how can I get that again? So that's how addictive some of these things are. I know you guys talk about that stuff, and you're not like, I'm not here to preach to you, but it's people like us that can get hooked on that stuff. You guys didn't watch ER. That was like way gone before you were watching TV, right? Yeah, George Clooney. Do you remember? Did you see any of the episodes where Carter starts using opioids? He gets hooked on opioids because he had some kind of injury or something, and he was taking some pills. And then instead of wasting the opioids that they were using for people in the ER, he started shooting them up. It was very entertaining. But obviously, It can happen to anybody. I think one of the highest incidences of drug use are in anesthesiologists, right, among clinicians. That's still a statistic. So we have substance use disorder clinic or SUD clinic for anybody that needs it. Part of integrated into our whole realm of practice at Jordan Valley. I spoke a little bit about the psychiatrists. We have difficult patients. We can ship them over there. They'll get them stabilized, send them back to us. Trying to think of who else we have that we work with. OBGYN, if I have teenage girls that come in, they want to get on some birth control. They need an Implanon or an IUD. I don't do Implanon. I probably should, or Nexplanon. I think it's Nexplanon now. Sorry. Yeah, Implanon was before Nexplanon. Before that, it was something else. They change the name every few years so they can probably keep patents and make them safer. They can keep them expensive. But I don't do Nexplanon. They're super easy. But if I have somebody that wants an Nexplanon or an IUD, I can just walk them across the hall to our women's health group, and they can get them in a lot of times same day to do their consultation, have them come back and put in their IUD. Of course, we do Depo, Provera all the time. We prescribe birth control too. What else for integration? You guys get any questions about integration or how that works for us? Yes. Well, state your name and your question.
I'm Ivan.
Ivan. Okay, Ivan.
And so if you have a really complex patient, never been to a doctor, so we have, you see them, you're like, oh, do so many things for this patient. How do you go about triaging where they should go first?
That's a great question. So I don't see that a ton in pediatrics, but I do some attending over at the residency as well. And that's basically what walks into Jordan Valley all the time. So we have patients that come in, they've been sick for 5, 10 years, and they haven't seen a doctor in ages because, well, maybe they just finally got on Medicaid. And before they didn't have insurance, so they didn't have the money to do it. But, they might come in, they've got diabetes, they've got heart failure, they've got high blood pressure, they've got swelling, lymphedema all over the place. And so you just kind of have to take one system at a time, just like you would with an ICU patient, and work on those different things a little bit at a time. The good thing is you can bring them back frequently, typically. So I try to teach my students, we don't have to address, or the residents, like, you don't have to address everything today. Tell them to pick their top 3 complaints, and let's work on those. Once we get those kind of under wraps, we'll work on the next thing. But certainly, I think you triage based on what is causing the most harm, or maybe sometimes you triage based on what their priority is. But you can't always do that because, you'll have people come in and their A1C is 14, but they're worried about their toenails or their toenail fungus. Like, hey, let's not worry about toenail fungus. We got to get your sugars under control first. Then we can treat your toenail fungus. Or maybe they got a big infected sebaceous cyst on them that needs to be IND'd, and they're really worried about their blood pressure being 140/90. And you can certainly start medicine on that too, but it's like, let's take care of the important thing first. Thank you, Ivan. Other questions about integration? Let's see. Any of you guys planning on doing primary care when you get finished with school? Maybe. We got a few yeses, a couple maybes. Okay, what are the rest of you guys going to do? What are you guys going to do? No primary care? Okay, primary care. ENT, all right. Primary care. Neurology, okay. That sounds like fun. At least they're getting some things that we can fix now. When I rotated, no offense, when I rotated through neurology, I was like, man, this is kind of a depressing rotation because you see all these people and you diagnose them, but we can't do anything about it. But with technology and new meds, we're getting some things that we can fix now. That's pretty exciting. How about you guys here in the back? Surgery? Okay. Way to heal is with cold steel. That's one of my favorite quotes. To cut is to cure, right? Surgery is awesome. How about you guys here in the back? Primary care and ER. That's kind of primary care. Yeah, that's good. Adam, are you doing family medicine? Is that your plan?
I'm kind of waiting for.
Okay, okay. You just have the old people in internal medicine. Well, 18 and up. 18 and up. Who we do? Oh, that's true. Oh man, I didn't mention PACE. Yeah. Y'all, have you ever heard of the PACE program? Yeah, I'll tell you about that. How about you over here, young lady? Family medicine, great. Psych and emergency, great. How about you guys over here? Emergency and peds, all right, go peds. Liam, have family medicine. OB, great, yeah. We need some more OBs in our OB program. How about you? Critical care, fantastic. Yeah, critical care is very exciting. I think that's a fun too. You guys definitely have a good spread, lots of primary care in the room. So, did I ask you guys? You said primary care. Okay.
Yeah.
Okay, very good. So, lots of good ideas. The PACE program. So, I forget what PACE stands for, but I know it's All-Inclusive Care of the Elderly program. Program for All-Inclusive Care of the Elderly. So, in the back half of our building, we are putting in a PACE program. So, PACE programs are foundation-wide, and it is a program for all-inclusive care of the elderly. So the way that works is we're going to have an on-site physician. We will have on-site physical therapy and occupational therapy. Not sure about speech. Not sure about that. Because old people need speech therapy too, especially if you've had a stroke. That's really huge. Speech therapy are huge for them. We'll have dental care. We'll have optometry care. We'll have behavioral health. And basically, for people who are 55 and older, it's like a little retirement sort of community center. And if they qualify for the program or pay for the program, they will come and hang out at the Jordan Valley PACE program. It's a really nice area. They'll have lunch catered in every day. They'll have snacks available. They'll have activities. They've got like a couple lounge areas with TVs. They'll get their medical exams, they'll get their vaccines, they'll get their dental exams, all inclusive care. And so I think we have room for about 150 is what our CF or COO says right now. So we're going to have lots of older folks in there. So for those of you interested in internal medicine, it'd be a fun place to work because you get to take care of these people on a regular basis, have all kinds of fun interactions, I'm sure, play some bingo, whatever activities they're going to have to do, make some arts and crafts, do a painting. Yeah.
Fun, like what they're building. And really, it's great for the families. Everyone it's based on a model that will help be like nursing home diverse. So like they would qualify almost for a nursing home, but we will keep them in their home. We actually will even go to their home and identify their patients. So we will have someone that will go in and say, this is a fall, they need a ramp, they need something to hold on to here, they need this, they need that. So it really is, again, that full wraparound model that Jordan Valley is known for, and that's why PACE is a great system.
Yeah. So it is, they'll go with buses, they'll pick these people up. And the goal is to help these people continue to age and age gracefully in their home rather than going to a nursing home. So I think it should be a neat program. All right, what other questions do you guys have? Yes, ma'am. Okay, what's your name? Zenobia. Okay.
What is the average patient that you get? Is it a lot of Medicaid patients?
Yes.
Do you offer any free services?
Mostly Medicaid patients, especially for the pediatric side. For the adult side, we mainly do Medicaid and Medicare. what we call dual eligible or dual enrolled patients. So they have Medicaid and Medicare if they're above 65 or if they're disabled.
We would kind of had a different morning this morning.
But that's the majority of our patients. I'd say maybe 85% of our payer source is Medicaid. We probably have 5% insurance and maybe 10% self-pay. So a lot of cash pay. Do we offer free services? Technically, no, but we do have a slide program. So based on your income, we can drop our fees. That's one of the advantages we have over the other health programs in town, whether it be Cox or Mercy, because they contract through HMOs and they have some sort of regulations because of that, because of their Medicare billing. They have to bill every patient the same. So because we're an FQHC, we fall out of that realm. So we can bill patients based on their ability to pay. So we do have, I think, 4 tiers of slide now. We used to have like 2. So based on your income, like a regular office visit, maybe $100. What are we at, 120 now? For office visit, 115? Yeah, but on slide, it may be $40 or 50 or 60, depending on which level slide you're on. When I first came to Jordan Valley, a new patient visit was $100 cash. And that didn't include all of your labs, but it might include some labs. For instance, it might cover a lipid panel and a CMP, but it wouldn't cover, anything exotic. A return visit was $50 cash. So I think a new kid was only $50. So new patients for kids was $50. Return visits were $50. For adults, new visit was $100. Return visits were $50. And then, of course, over time with inflation and the increased cost of doing business, that's just gone up a little bit. But we don't offer free services, but we do have a fund that anybody can contribute to. You guys, any of you are independently wealthy, you can contribute money to the Jordan Valley, what's it called now? Crisis Fund, Jordan Valley Crisis Fund. I2 Care, thank you. So the I2 Care is a fund that we have available that a lot of the employees contribute to. And so if we have somebody that really needs their medicine, they don't qualify for Medicaid, they can't get their medicine, they can't pay for it, we can I2 Care it. So we'll just send the medicine to our Jordan Valley Walgreens. We put I2 Care Fund in the memo line of the script, and they get there and their medicine's covered by our I2 Care Fund. We can also pay for x-rays like that. So we could do a whole visit that way, but you want them to have a little bit of ownership of their health care, because as you may have seen, as you get old like me, you realize that if you give people things for free, they don't value it, and they don't really take ownership of it. So we try to let them take a little ownership of their health care by investing a little bit in it. They don't have to invest a lot necessarily, but they need to invest a little bit, and it will help them out for sure, get to where they need to be. That's also true with any rehabilitation weight loss program. I don't know if you guys have studied that or talked about it in your lessons, but if you take an exact replica or exactly the same comparative weight loss program and you charge $10 a month for one and the other one you offer for free, people are more successful with a $10 a month plan because they're investing in it. Because they're paying for it, they're more invested in it personally. So, what's that? That's right. They got a little skin in the game. We want our patients to have a little skin in the game too. Yes, Zenobia. I just wanted to say that name.
When you send patients out of Jordan Valley, because you don't have any surgery options available.
We do have some surgery options. Okay. We do minor procedures in the office.
Okay.
I do vasectomy still, even though I do pediatrics. Yeah, we do circs and vasectomies. I do vasectomies. My pediatricians don't do vasectomies. But we do minor procedures. We also have a surgery center, outpatient surgery center in the building that we have now. So we do a lot of dental operating surgery, root canals, crowns, oral surgeries. We do a lot of that. We also are now doing some GYN surgeries. Our OBGYN team, since it was difficult to get that approved and qualified and jump through all the red tape to get that running, but they have it running now. And we also have an ENT. The ENT guy, lady, thank you. We have an ENT from Mercy, Dr. Gottschalk. You know Dr. Gottschalk? Dr. Gottschalk is going to come over and do some procedures in our outpatient surgery center. Otherwise, we refer to Mercy and Cox. Correct. Equally split, I don't know. When I first came, we were sending most of our patients to Mercy because we had a good relationship with Mercy. Over time, we've developed more connections with Cox as well. When I first started at Jordan Valley, we were only seeing babies at Mercy. Cox came to us and said, the residents are all lazy. They won't see babies. I'm just kidding. We got a resident over here. So they had so many babies, and a lot of pediatricians were aging out of the call box because at age 55, you no longer have to take card file patients in pediatrics, according to Cox. And so they asked us if we would start taking some card file babies there. So we said, well, let's see if we make that work. And we did. So now we round at Mercy and Cox. So we stay pretty busy. So card file baby is a baby that comes in. Mom comes in to deliver. Maybe they did their prenatal care at Cox, Mercy, or Jordan Valley. They come in to deliver, and maybe they're from Ava. And so they don't have a pediatrician who's going to come see them in the hospital. So they just assign them to somebody randomly. So if you go in the emergency room and you don't have an internal medicine doctor who does admits, you're a card file patient. But they used to be card file patients. So the internal medicine docs or family practice docs who took card file patients, it was a way to pick up new patients and also a way to keep you busy in the hospital. So nowadays we have hospitals programs everywhere. So hospitals programs kind of did away with the card file from emergency room admits. We have, pediatric hospitalists, we have adult medicine hospitalists, and we even have OB hospitalists. So if you come in and your OB is in Branson, but you've got a problem and you got to go to Springfield, you either get to come see the residency or you get an OB hospitalist. And so we don't have newborn nursery hospitalists because there's probably not really a need for it. It doesn't take that much time to see, a few newborns. They've talked about that, I believe, at different places, but I don't know if they'd be able to afford to pay somebody what somebody would want to make to do that job. So that's card file babies. If you don't have a pediatrician, you get assigned to a pediatrician. And so we take a lot of the card file babies at Cox. We don't take card file babies at Mercy because they have some newer pediatricians who want to get all the card file babies there. But a lot of our moms that do prenatal care at Jordan Valley do go to Mercy and deliver. So today, for instance, I had a busy day of rounds. I don't remember if all you guys rounded with me or not, but I had 8 new babies today and 2 babies from yesterday left over. So thankfully no circs. So I made it here on time. Man, we're almost at 1 o'clock. I didn't think I was going to be able to talk that long. Why are you laughing, Adam? All right. Does anybody have any other questions about integrated medicine? Are you the next speaker? All right. What are you teaching on today? Case study. All right. Very cool. Case studies are fun. That was my favorite thing in med school. Grand rounds and case studies. No other questions? Hey. Yes. Yes, Summer.
But what about your recent change
That's-
in job?
Oh, my recent change in job? Oh. So do you mean why I stay at Jordan Valley? Okay. So I went to Jordan Valley through some circumstances that were not necessarily my choosing initially. And my thought was, well, I'm going to write out my non-compete here, and then I'll go back into private practice because I really didn't go to school to go to public health, to do public health. And it was kind of a difficult transition. But once I was working with the kids and the families, we started doing more and more integration. And I was like, man, this is really incredible. I'm able to accomplish so much more here with my patients and get them so many more services. And I thought, man, this is really a great service to the community. I really enjoy the people I work with. And I thought, I think I'm happy. I think I'm going to stick it out here at Jordan Valley. So I initially went there. I had some loan repayment going on. Anyway, some different circumstances. So I had to work in FQHC to continue my loan repayment service. Otherwise, I was going to have to pay National Health Service Corps, which is a great way to pay for school, by the way. I would have to pay them back thousands of dollars. I didn't want to do that. So I was like, yeah, I'm going to go to Jordan Valley. But anyway, so that's why I stay at Jordan Valley. It's a great place to work. There's great benefits. The retirement match is unparalleled, actually. Anywhere else I've ever talked to or seen. I was trying to figure out the other day exactly what that was, but I think she's wanting me to talk about. I just recently became the medical director of the pediatric department and therapy departments at Jordan Valley. So that was, I think I basically got the job because no one else wanted to do it. But I have been there a while, and I've seen a lot of people come and go, and so I'm really thrilled to be able to do that, and hopefully continue to make good progress for our department and take good care of patients. So there you go. Thank you. No applause necessary.